Okay, good morning, everybody, and really happy to be here and to join you in this very nice conference. I'm really impressed with the number of audience and the organization. Thanks for the organizing committee also for inviting me. And I'll talk about this very debatable topic, which is APRV for ARDS patients and whether there is any evidence to support it or not. So first of all, I have no conflict of interests, and I'd like to go over my presentation outline. Number one, I'll talk about background and concepts of APRV. Then is APRV standardized? I don't know that the mic is working. Is it? Okay. Then theoretical benefits of APRV. Does LTV, which is low tidal volume ventilation, plus paralysis prevent VILI, as Dr. Abu Shala mentioned earlier, or not? Has APRV been tried in ARDS? Does it improve mortality? Latest ARDS guidelines regarding APRV, and then latest data followed up by the conclusion. This is the one? Okay. So first, background. Now, APRV, let me just take this one. I know it cuts all the time, right? That's okay. Now, APRV has been introduced by these two physicians, Dr. Downs and Dr. Stock from Ohio State University. And they published their first paper about APRV long ago, 30 years ago, in 1987. And this is how the ventilator wave looks like. It's very, very strange, as you can see, and people didn't buy it. A year later, what they did is that they published their first human data or trial. And as you see, they started with 14 consenting adults undergoing cardiac surgery, and they applied both positive pressure ventilation and APRV to all patients during surgery and at recovery, and they started to measure certain physiological parameters during that period. And what they noticed is that the APRV supported oxygenation and ventilation very well, and that was in mild acute lung injury cases. And also they noticed that there is lower peak airway pressure if compared to the positive pressure ventilation. Now, their conclusion, besides the fact that APRV does not impede cardiac performance, is that further study will be required to determine whether this mode of ventilation is useful in population of patients for whom it was intended or designed, which is patients with severe acute lung injury or ARDS. Now, a little bit of concept of APRV. This is the CPAP wave. You apply some sort of continuous positive airway pressure, and the patient can't breathe around it. Now, the only difference here is that there are certain, dips in the pressure. We call them release phases from P high to a P low, which could be 0 or 5 or 10, whatever. And the patient will still breathe around the APRV. Now, the inspiration phase is called, duration of this inspiration phase is called T high. The duration of the release phase is called, T low. And, the release phase is important because it helps the lung to ventilate and releases PCO2. So it's look very much like mandatory pressure controlled ventilation with inverse ratio kind of thing. But people started to be more creative, and multiple forms of APRV were created where, for example, biphasic form, where the inspiration and release phases are equal in this particular case. And this moves us to the next thing, which is APRV standardized? The easiest answer to this question is probably no. This is the first study that I've spoken about, which is the first human trial in APRV. And in this particular study, Dr. Downs and Dr. Stock started with lower pressure, which is 10 to 12 cm water as P high, while the P low was around 0, which is near ambient, and they continued for 1.5 seconds of these release phases. Now they adjusted the frequency based on the outcome of the PCO2 and pH. And it looks very much like this one as I've shown earlier. But if you look at different studies, you'll find that it is all over the place. The P high, P low are totally different from each other, and the T high and T low as well. So standardization is not there really. What we use in our center is that we start with a P high of 20 to 30 and P low of 0 to 5, T high of 4 to 6, and T low of 0.2 to 0.8. And then the RR will be determined by the T high and T low. Subsequent adjustment will be based on the volume pressure curve. You would like your patient to be in the steep portion of the pressure volume curve so that you don't have high pressures, peak pressures, and not high volumes. And we'll talk about this a little bit later. Now, weaning will use a drop and stretch algorithm that we don't have time to talk about. So any theoretical benefits of APRV? The answer is yes. Remember, mean airway pressure depends on the number of breaths, the peak airway pressure, etc. And it's very low in a CMV, as you all know. But with CMV, it's better. With APRV, in fact, it is much higher than the CMV. So despite the fact that you are not giving too many tidal volumes, the mean airway pressure is higher. And the higher the mean airway pressure, the better the oxygenation, as you all know. Despite that, the peak pressure is lower than the CMV, as well as the PEEP. So lower peak airway pressure, lower PEEP means lower ventilator-induced lung injury. Now, the tidal volume will remain, in fact, constant in both CMV and APRV. Now, the inspiration phase is prolonged, as you could see here, and it helps oxygenation, while the release phase, as I've mentioned earlier, helps ventilation. The patients allowed to take breaths during APRV, which means sedation and paralysis are much lower. So if you plot this in the volume pressure curve, you'll notice that APRV, despite having a similar tidal volume, similar mean lung volume, it is still in the steep portion of the volume pressure curve, which means the patient can breathe comfortably here without causing much of damage to the lung. While with volume control that we use currently for ARDS, we are at the higher area of the volume pressure curve, which means that we are exceeding the upper inflection point, causing more overdistension and more damage. Now, in summary, so APRV has similar mean lung volume and tidal volume as compared to low tidal volume ventilation. It has higher MAB, which means higher oxygenation, lower PEEP and peak airway pressure, which means less overdistension and VILI. Now, there is efficient oxygenation and CO2 removal, as I've mentioned earlier. It allows spontaneous breathing, which was noted to be comfortable. This is, from data taken from physicians and RTs who did APRV on themselves, and they felt comfortable, having this kind of procedure on them. Active diaphragm, so will prevent diaphragmatic atrophy that we face with ARDS patients, and decreased work of breathing. There is no time to discuss the mechanics of that now. So less sedation, less paralysis, problems recovery. Now, this is all theoretical. Now, next thing, does low tidal volume ventilation and paralysis prevent VILI or ventilation-induced lung injury? As Dr. Abu Shala mentioned, the answer is yes. But there is a paper that was published fairly recently in September of 2017, just a few months ago. And this paper is quite interesting. What they did is that they allowed patients to breathe spontaneously while on volume control with ARDS, and then they paralyzed them, and they did tomography to the lungs. And what they noticed is that there is more recruitment of lung during inspiration and expiration as compared to the paralysis limb. And this infers that there is more acute lung injury or ventilator-induced lung injury in the paralysis limb. Now, I don't have time to talk about that. I'll show you this little rat here. So in animal models, the PEEP that they have used or generated by the short P-low, so you have short T-low here in APRV, showed more gas in the alveoli at end expiration, which means recruitment is sustained at end expiration, which is similar to what we call O2 peeping. And this is much better in this particular rat study than the conventional PEEP that is used with low tidal volume ventilation. Now, has APRV been tried in ARDS? The answer is yes, of course. This is one of several studies that used APRV in ARDS, retrospective observational one, 50 patient, small study. And first of all, APRV has been shown to be safe in patients with ARDS. It improves PF ratio, improves oxygenation and FiO2. So this is one of several. We'll just skip it for time's sake, and we'll go to next question. Does APRV improves mortality? And probably the answer to this question is really hard. And to date, there is no strong evidence to support that. But let me go over this study that tried to address this in 2013. It is a systematic review of observational trauma ARDS literature. And now, this study involved 16 studies. And the first one of them is a study that was published by the center where the study is arising from in Maryland, which was published in 2009. And they used early APRV in all trauma patients who came to them with or without ARDS. And they compared that to the remaining 15 studies. And let me show you the results. This is the baseline characteristics that I'll skip for time's sake. So, first of all, as you see, the ISS, which is the injury severity score used for trauma patients, is quite wide, but the early APRV group has higher than the rest of the studies in terms of ISS. So the patients in this group are sicker. The other thing is percentage of ARDS that developed as patients are managed with mechanical ventilation. It's also wide, but patients in the early APRV group had the lowest incidence of ARDS throughout the study, which is 1.3%, which is quite amazing. Now, mortality, which is the thing that we are actually looking at, is far lower in the APRV group as compared to the remaining studies, which is 3.9%. Whether that is related to APRV itself or to something else, it's hard to tell. But it's quite interesting. Now, this is the early APRV group. It contained 231 patients. And as I've mentioned, the incidence of ARDS is low, and none of the ARDS patients died in that particular study. Again, this is the only paper with mortality benefit of APRV. It concentrated in a single subtype of patients, which is the trauma patients. It is a systematic review of retrospective observational studies, and it talked mainly about prevention of ARDS. So this is another study that has totally the opposite in trauma patients. It was published in 2010 and showed that APRV has similar safety profile as LTV, similar oxygenation despite higher MAP, which means that there is decreased pulmonary flow, and there is trend to have increased ventilator days, ICU length of stay, and VAP. But in this particular study, there was initial worse physiological derangement in the APRV group, and the study is small. The other strange thing is that patients in APRV had more sedation as compared to patients with LTV, which is quite strange. Now, latest ARDS guidelines were published in May of 2017, and involved American Thoracic Society, European Society of Intensive Care Medicine, Society of Critical Care Medicine, and it talked about mechanical ventilation patients with ARDS, adult patients, of course. And I reviewed this particular guidelines, and there's nothing whatsoever mentioned about APRV except that questions regarding some modes of mechanical ventilation, namely APRV, were not addressed because of resource constraints, which means that they don't have enough data to help them assess APRV confidently. So immediately after that guideline was published, a study came up. And this study is very important, and I'd like you to pay some attention here. So it talked about early application of APRV in patients with ARDS and showed that it may reduce duration of mechanical ventilation in these patients. This study was published in late 2017, and it had a total of 138 patients. All of them fulfill a criteria of Berlin definition for ARDS PF ratio of less than or equal to 250 millimeters mercury. And the primary outcome was ventilator-free days by day 28. And these patients were randomized to either APRV or LTV 71 to 67. And the results were marvelous. In fact, the plateau pressure in the APRV group, which is the orange one here, has dropped significantly by day 7 with significant p-value. Now, the MAP, as you would expect, is higher with the APRV group. There is also a reflection of that on the compliance, which is a physiological parameter. As you see, the compliance is better in the APRV group with significant p-value as compared to the LTV group. PF ratio has improved significantly in the APRV group. Even the heart rate, despite the fact that the patients were awake or semi-awake, it's better in the APRV group. And the RAS, of course, is better in the APRV group. The other thing is that sedation, as expected, is lower, much lower in the APRV group, including fentanyl, midazolam, and propofol. Breathing without assistance is higher in the APRV group compared to LTV group. And there are so many other parameters that were also better. For example, tracheostomy is better in the APRV group. Successful extubation is better in the APRV group with significant p-value. But the only thing that we have some issues with is death during ICU stay. It was better in the APRV group, but with insignificant p-value. Length of stay in the hospital is better in the APRV group with insignificant p-value. And death during the hospital stay, same thing. It's better in the APRV group, but with insignificant p-value. Similarly, we have better outcome with neuromuscular blocking agents, recruitment maneuvers, and prone positioning in the APRV group. So the conclusion of this study is the following. Compared with conventional LTV, the early application of APRV in patients with ARDS was associated with better oxygenation, better respiratory system compliance, lower plateau pressure, less sedation requirement, more ventilation-free days at day 28, and shorter ICU length of stay. So limitations to this study include, this study is small, single center, unblinded, no significant mortality benefit, no significant shortening of hospital length of stay, and I mentioned that already. And I'd like to conclude before time is up. So this is the conclusion. I'd like you to pay attention here. Number one, APRV is safe. This has been shown in human studies. You can use it as rescue therapy or upfront in ARDS patients. It has remarkable theoretical and animal data benefits. Based on at least two of the studies that I've mentioned, there is possible superiority if used early, but there is no significant mortality benefit. Lack of standardization is a weakness of APRV. Until now, people use APRV the way they want, all over the place. There's no data in patients with obstructive airway disease, and this is concerning because remember we use inverse ratio ventilation here, so there's a problem of overdistension and auto-peeping, although some will consider this of benefit to patients using APRV. And I'll personally recommend using it in case conventional LTV failed, and try it, see what happens. Of course, it needs more research before wide-scale use. And by this, I will end. Thank you very much.
Okay, so we're open for a couple of questions.
Yeah, you can remove this one, yeah.
About the effect of APRV on the stroke volume and cardiac output, is it studied or not?
Well, it has been studied as well. In fact, the first study that I've mentioned of Dr. Downs and Dr. Stock, they inserted Swangans, and they were capable of measuring the cardiac output in these patients. There is no impedance whatsoever in the cardiac performance. Now, the rest of the studies, it wasn't as extensive as that one. But so far, there is no evidence, clinical evidence, that cardiac output will be impaired with the APRV.
For about the aspiration pneumonia, we have more negative pressure. It is affect aspiration pneumonia?
Sorry, there is more aspiration pneumonia in APRV?
Yes.
I haven't come across any report that suggests that.
Yes, about APRV. We know we start gradient setting by 0 kilo. But we have short time, and this will create OTP.
Right.
How come the patient in this time 0.3 second or something this, or sorry, from 0.3 to 0.5 seconds?
0.8.
Is it enough? No, sorry, 0.8. Is it enough for the patient to trigger or initiate any blood?
Is there going to be any auto-peep with APRV? The answer, it's possible, especially in vulnerable patients. But when it was tried in patients without airway obstruction, there was no auto-peeping. In fact, they considered the short T-low is of benefit because it will keep the, the alveoli recruited during exhalation. Yet there is no data in patients who are vulnerable to auto-peep, like patients with airway obstruction, like COPD, for example, or bronchial asthma. So I cannot answer this question with confidence based on these studies. Remember that APRV has been there for 30 years. It was never studied, extensively except recently. It remained forgotten for probably 15 years. So more data are needed to understand this type of ventilatory support.
Okay, one more question. If we have APRV and we have new filtrators now, are you with pressure support or only spontaneous breath without pressure support?
You mean the weaning?
Above the behind.
It is no, without pressure support. So the patient will breathe without pressure support on his own. One of the the speakers in one of the conferences tried APRV on himself. Of course, he had a normal lung, and at a pressure high of 25, he was capable, he was conscious, he was capable to breathe comfortably without any problem. Now, we cannot compare this to patients with sick lungs, right? But at least there is nothing to suggest that it will increase work of breathing.
Okay, thank you very much.
Thank you.
Okay, so now,
Thanks.